Our next professor is Dr. Mohammed Makharita, who is going to educate us on prevention and management of post-herpetic neuralgia. Thank you, Professor.
Thanks, Barbara, for your introduction. My talk today about prevention and management of post-herpetic neuralgia. I have no cause for disclosure. This lecture, based on our experience in Egypt, documented by a series of publications in high-ranked, respectable pain journals. First, I will discuss a case scenario. 75 years old diabetic male patient presented to ENT department with severe pain in the left side of the face, especially at the region of the left ear. For 4 days, patient was admitted and diagnosed as severe otitis media. Patient received intravenous antibiotic and analgesic. 3 days later, vesicle appeared over the left side of the face and the left ear, and the diagnosis of acute herpes zoster was confirmed. Intravenous acyclovir was added, and patient complained of intolerable facial pain and inability to sleep. Therefore, they asked for a consultation from our pain unit. This is our patient. Notice his old age, and notice the vesicle over the ear and the face. This is Ramsay-Hunt syndrome, which is affection of geniculate ganglia of the 7th cranial nerve. It may followed by post-herpetic neuralgia, facial palsy, and hearing loss. So it is a disastrous condition. Another case scenario, 77 years old female patient referred to our clinic from OPD, from the neurology department, with intolerable left supraorbital pain and inability to sleep. History of left ophthalmic branch herpes zoster infection 3 months ago. Family members were present with her in OPD and were anxious about the case. This is our lady, old age female with supraorbital with ophthalmic branch herpes zoster followed by post-herpetic neuralgia. Notice the scarring over the supraorbital nerve and over the left forehead. Now my question, is there any difference between the two cases in the management? This is the result of our discussion today. Therefore, the objectives of our talk, first, to review the pathophysiology of post-herpetic neuralgia, discuss the evidence for post-herpetic neuralgia prevention and the treatment of post-herpetic neuralgia either by medical therapy or intervention pain therapy. Varicella zoster virus is the causative agent for chickenpox in children and herpes zoster in adults. During the primary infection, the virus goes through the nerve from the skin to be dormant in the dorsal root ganglion. Then, if cell-mediated immunity depressed, the virus will go to the other direction to the skin, causing herpes zoster eruption. If viral reactivation occurs, the virus travels along the peripheral nerve to the nerve ending, producing pain and skin lesion. Viral reactivation causes ganglionitis and neuritis, causing pain along the segmental distribution of the nerve. Clinical diagnosis of herpes zoster is made once rash appears. Before the rash appearance, there is a dilemma of differential diagnosis. 50% of herpes zoster are thoracic. The commonest is dorsal 5 and 6. 20 are trigeminal. 20 are cervical, and 10 are lumbosacral. Clinical presentation of acute herpes zoster, general symptoms in the form of fever and fatigue, but herpes zoster pain is unique. It is unilateral, shooting, stabbing, band-like dysesthesia, hyperalgesia, and allodynia. Pain precedes skin eruption by 5 to 7 days, and severity of the skin lesion, pain, and pain duration were exaggerated with the increase of age. Usually pain, hyperesthesia gradually decrease, and healing occur in 4 to 6 weeks. In some, pain persists, producing what is known as post-herpetic neuralgia. This is one of the most important slides in my presentation. Risk factor for acute herpes zoster. First, age. Old age are high risk group. Malignancies, especially lymphoma, immune suppressive drug, chemotherapy, radiotherapy, and steroid. Malnutrition, diabetes, HIV, and chronic debilitating disease like TB and renal failure. This is the risk factor for development of acute herpes zoster. But what are the predictors to develop post-herpetic neuralgia? Transmission of acute herpes zoster to a post-herpetic neuralgia. You can predict which patient will develop post-herpetic neuralgia. In addition to the previous factor, age is the most important factor for development of post-herpetic neuralgia. There is threefold increase in the incidence of post-herpetic neuralgia by the age of 70. Severity of the acute herpes zoster pain. The more severe the pain, the more likely to develop post-herpetic neuralgia, because this means severe ganglionitis and neuritis in the affected nerve. Density of eruption. The more dense, the more likely to develop post-herpetic neuralgia. Ophthalmic branch per se or trigeminal herpes zoster is one of the character of post-herpetic, is likely to develop post-herpetic neuralgia. Even in young age, patient did not receive appropriate antiviral therapy because the antiviral therapy has a protective character. Remember the predictor for post-herpetic neuralgia, please. This is a case of post-herpetic neuralgia. Notice the pigmentation, and this is associated with allodynia and pain in this pigmented area. Post-herpetic neuralgia either self-limiting disease, mild, or severe constantly burning dynamic allodynia with skin pigmentation. Post-herpetic neuralgia affects the quality of life. Many patients develop severe physical, occupational, psychological, and social disabilities. Therefore, it is desired to avoid this disastrous sequelae toward a more benign self-limiting disease. What is the pathophysiology of post-herpetic neuralgia? This is the nerve, and this is the endoneural artery, and viral inflammation induces profound sympathetic stimulation, causing the vasoconstriction in the endoneural artery, reducing ischemia and reduce blood flow and in the intraneural capillary bed. If ischemia persists, endoneural edema forms in this area, and increase endoneural pressure, more ischemia will result. Further decrease in the oxygen, nutrition of the nerve and the blood flow, and producing irreversible nerve damage and scarring. So the whole picture is vasospasm of the endoneural blood vessel. This damage will destroy the large myelinated E beta fiber, which are metabolically more active, and spare the small fiber responsible for pain, which is the C fiber. Therefore, there is loss of the gate control and loss of the inhibitory control over the incoming pain signals. Therefore, pain become continuous and more severe. Complications of acute herpes zoster include pneumonia, encephalitis, facial palsy, herpes zoster ophthalmitis, including ulcer, iritis, and keratitis. Secondary infection, post-herpetic neuralgia is the most common complication of post-herpetic neuralgia, of acute herpes zoster. This is a case of lymphoma suffering from secondary infection. She suffered from acute herpes zoster and secondary infection, septicemia, and end by this. This is keratitis. It's a shame in 21st century to find a patient like this. And this is a facial palsy associated with Ramsay-Hunt syndrome or facial palsy associated with facial herpes zoster. Misdiagnosis of pre-eruptive stage of acute herpes zoster. Before eruption, you can't diagnose acute herpes zoster. You can suggest only acute herpes zoster if the pain is dermatomal. Myocardial infarction is one of the misdiagnoses, cholecystitis, appendicitis, and glaucoma. Now, management of herpes zoster. What is the aim of our management for a case for acute herpes zoster, like the first case scenario? To relieve pain and reduce its severity? Yes. Reduce duration of the attack and reduce the patient suffering? Yes. Reduce the duration of eruption? Yes. Prevent the complication. This is the most important target of our strategy. Management of already presented cases with post-herpetic neuralgia. Prevention of post-herpetic neuralgia is easy, but treatment of post-herpetic neuralgia is a challenge, and the result is disappointing. So I believe that one action can make a huge difference. Therefore, our mission is to increase the awareness about the new strategy for prevention of post-herpetic neuralgia named the 10-step model for prevention of post-herpetic neuralgia. What is our strategy for prevention of post-herpetic neuralgia based on evidence-based medicine? We can use varicella-zoster vaccine, systemic antiviral therapy, medication like antidepressant, anticonvulsant, opioid, and systemic corticosteroid. Sympathetic blockade for prevention of post-herpetic neuralgia can be also used. Varicella-zoster vaccine is given during the childhood period in developed countries, and this decreases the incidence of chickenpox with subsequent reduction in the incidence of acute herpes zoster and its reactivation, and therefore there is account for reduction in the incidence of post-herpetic neuralgia. There is reduce the incidence of acute herpes zoster by 51% and the risk of post-herpetic neuralgia by 66%, and it is approved by FDA in 2006. So we can use vaccination for children and booster dose for other all elderly patients which has susceptible for development of acute herpes zoster, like immune-compromised patient on steroid or chemotherapy, radiotherapy, and elderly per se. Antiviral therapy. Topical antiviral therapy is not effective, but systemic antiviral therapy is effective. We can use acyclovir, valacyclovir, famaciclovir, and the duration of treatment is extended from 7 days up to 10 days if there is new eruption. Acyclovir per se must start in the first 3 days of eruption, and the dose is 800 milligrams 5 times per day. The usage of appropriate antiviral therapy was associated with 50% reduction in the incidence of post-herpetic neuralgia at 6 months. This is a great achievement. Antidepressant, amitriptyline. There is only single study discussing the value of amitriptyline in preventing of post-herpetic neuralgia in 1997, and it is old study and not reproducible, not replicated, and this is the weakness in this study. To myself, I didn't believe that amitriptyline early can prevent post-herpetic neuralgia. Even I did not use amitriptyline for my patient because my patient is old, can be suffering from comorbidities like advanced cardiac condition, senile prostate hyperplasia, or glaucoma. The three are absolute contraindication for use of amitriptyline. So the use of amitriptyline on old age is questionable and need no comorbidities like cardiac condition. So in this randomized double-blind study, it is single study, but it is randomized double-blind study, so it appears in the evidence. Anticonvulsant like gabapentin and pregabalin can be used as adjuvant with sympathetic blockade. They may be useful in relieving persistent paresthesia, dysesthesia, and allodynia. But remember that it has no value in prevention of post-herpetic neuralgia. It can alleviate pain, decrease pain in conjunction with the sympathetic blockade, but it has no value in prevention of post-herpetic neuralgia. Opioid is the mainstay for short-term treatment of severe pain. There must be a clear understanding that opioids are to be used for a limited term in case of severe non-cancer pain. Barbara, the opioid stigma in Europe and in United States. This is because of the use of high doses of opioid for non-cancer patients. For acute disaster, tramadol and oxycodone can be used, and it is suitable anti-neuropathic medication. Systemic corticosteroid. A Cochrane review in 2010 found no significant difference between systemic corticosteroid and placebo in preventing post-herpetic neuralgia. However, this combination improves acute herpes zoster pain, patient quality of life compared to acyclovir alone. This allows quicker return to the work and improves the sleep better. So systemic steroid has no preventive effect on post-herpetic neuralgia, but systemic steroid improves the symptoms. This is for systemic, oral or intravenous. What about sympathetic blockade for prevention of post-herpetic neuralgia? Several study demonstration of inclusion of steroid with local anesthetic in the neuroaxial blockade for management of acute herpes zoster and post-herpetic neuralgia prevention. This is 4 studies. 3 of them are randomized clinical trial, and 1 is non-randomized clinical trial. What is the evidence from this study? By the year of 2011, the evidence in the evidence-based book in chapter 17, one-time epidural injection to be negative. Remember, it is one-time epidural injection to be negative, no effect. Repeated paravertebral and sympathetic nerve block to see positive. This is because of the opacity and few number of the studies. However, in the light of recently available randomized placebo clinical trials, the evidence must be reviewed. Recent studies include effect of early stellate ganglion block on the facial herpes zoster and the prevention of post-herpetic neuralgia. This is from Egyptian team, from Tanta and Mansoura University, by my colleague Yasser Amr and Yusuf Bayoumi and me. This is stellate ganglion block. And this is our patient suffering from Ramsey-Hunt syndrome. After certain days, there is improvement of his pain, no sequelae like post-herpetic neuralgia, or no facial palsy or hearing loss. This is a great achieve. This is the paper, and the incidence of post-herpetic neuralgia in the active group was significant after 3 months and 6 months. And the duration of pain also significantly reduced. For thoracic herpes zoster, the same team published another paper in the pain practice, which is big known journal. Single paravertebral injection for acute thoracic herpes zoster. This is a single injection. This is a paravertebral space and it contains somatic intercostal nerve and sympathetic fiber. So it is a sympathetic blockade, and the block can extend to the epidural space, producing epidural blockade in 70% of our patients. This is paravertebral block. This is very nice, showing the epidural spread. And this is one of our patients. And after about 3 weeks, there is improvement in pain. And the result of this study was that after 3 months, there is non-significant reduction in the incidence of post-herpetic neuralgia. Notice 15 versus 8, but it is not significant. After 6 months, there is significant improvement in the incidence of post-herpetic neuralgia. The duration of pain and the duration of eruption also improve in this study. In 2017, a systematic review and a meta-analysis found that this include about 800 paper, but only select 9 paper because of the inclusion criteria and avoid the bias in this study. So they reviewed a big number of paper, but included a small number of paper. And these 9 studies include our randomized clinical trial from Egypt. And also, these studies contain the least biased in its methodology. And the result is early sympathetic blockade can decrease the incidence of post-herpetic neuralgia significantly. Notice the diamond. After 6 months, also there is significant decrease in the incidence of post-herpetic neuralgia, and after 1 year. The conclusion of this study, early supplement therapy can significantly reduce the incidence of post-herpetic neuralgia. Supplement means that the drugs like gabapentin, pregabalin, amitriptyline, and TENS, in addition to the intervention. But subgroup analysis, they found that early systemic adjuvant like gabapentin, pregabalin, amitriptyline, and TENS has no significantly reduced the incidence of post-herpetic neuralgia. But early supplement intervention procedures has a beneficial effect on preventing of post-herpetic neuralgia with a high p-value. They concluded that every use of intervention procedure for acute pain from acute herpes zoster may be preferred choice for patient without contraindication, but the evidence is moderate. More data from high quality randomized clinical trial will be needed to confirm the result. This is in 2017. So the intervention pain therapy has a great role in prevention of post-herpetic neuralgia. In another paper, we wanted to put a strategy for prevention of post-herpetic neuralgia known as the 10-step model for prevention of post-herpetic neuralgia, published in Pain Physician in 2017, and is a 10-step model formed from 10 steps. First, awareness of the population and education of the healthcare providers about the nature of herpes zoster infection and its complication. Vaccination for children and the high-risk group. Early diagnosis of acute herpes zoster. Early use of antiviral therapy in optimal dose and optimal duration. Identification of risk factor for the development of post-herpetic neuralgia. As I mentioned, the age is most important factor. Stratification of acute herpes zoster into one of 3 groups. This is very important slide. Notice that if your patient is below 50 without risk factor, not diabetic, not immune compromised, not renal failure, no bone marrow transplantation, you can give antiviral therapy and symptomatic pain therapy without sympathetic blockade. But if your patient is below 50 and with 1 or more of the risk factor, diabetic, immune compromised, this patient will shift and deal with as if it is above 50. And the strategy will be antiviral therapy, symptomatic pain therapy, plus repeated sympathetic blockade. And sympathetic blockade can be used according to the region. Head and neck, stellate ganglion block. Truncal, paravertebral block, epidural, and thoracic sympathectomy. Lumbosacral, caudal epidural, lumbar epidural, or lumbar sympathetic blockade. This is repeated injection, at least 2 block, or continuous blockade for 2 weeks. This is our strategy. Optimization of symptomatic pain therapy, including anti-neuropathic drug, antidepressant, anticonvulsant, and opioid and tramadol, and follow-up of the patient and the detection of complication like keratitis, and good reporting, filing, collection of the data, and analysis of the data. From the 7th step, you can notice that the number and the frequency of blockade did not clarify it. I said that repeated injection at least to 5. Therefore, we conduct a new study accepted in the pain physician in 2020 in May. The effect of repeated paravertebral injection with local anesthetic and steroid in prevention of post-herpetic neuralgia by Dr. Yasser Amr from Tanta and me from Mansoura University. And from this study, we can find that 2 and 3 have equal result, but in patients with multiple comorbidities and risk factor, we prefer 3 injections rather than 2. Therefore, the golden rules in acute herpes zoster management: the earlier the treatment, the less likely to develop post-herpetic neuralgia. I mean, the injection must be done in first week of after eruption to avoid vasospasm and scarring of the nerve. In high-risk group, early aggressive treatment is mandatory. Treatment of post-herpetic neuralgia. Treatment aim in post-herpetic neuralgia is just to relieve pain and reduce its severity and improve the quality of life. It is almost a palliative to improve the quality of life. There is no cure from post-herpetic neuralgia. In some mild cases, there is spontaneous resolution of the case, but it is not the rule, especially in our community in Egypt and third world where there is no vaccination. Because vaccination, the attenuated virus cannot be reproduced and produce severe acute herpes zoster. But in our countries, there is no vaccination. So it is a wild virus producing acute herpes zoster followed by severe post-herpetic neuralgia. Treatment modalities for post-herpetic neuralgia includes symptomatic pain therapy and intervention pain therapy. This is the New England Journal treatment of post-herpetic neuralgia. This is the treatment modality, and this is the number needed to be treated, and the lidocaine batch 2, and it is approved by FDA, capsaicin batch 3.3, and it is approved, not approved by FDA, gabapentin and pregabalin, also approved by FDA by Take Care for the serum creatinine, because these drugs are 100% secreted by kidney. Take Care for serum creatinine, tricyclic antidepressant, it is off-label use. And remember the contraindication of amitriptyline, which is glaucoma, senile prostate hyperplasia, and advanced cardiac condition, because the amitriptyline can increase the silent deaths by 20 to 25% in advanced cardiac diseases. Morphine, oxycodone, and tramadol. Remember the risk of abuse, and remember that tramadol associated with amitriptyline in high dose may induce serotonin-like syndrome. This is the evidence for intervention. Acupuncture is not effective. Sympathetic blockade in already presented cases of post-herpetic neuralgia is not effective and better to be avoided. Intrathecal methylprednisolone is not effective, and please avoid it. Can produce fungal meningitis and arachidonitis. Excision of the skin, it is not effective. Botulinum toxin can be used in refractory cases, and it is effective, but the duration is from 3 to 6 months. Spinal cord stimulation, there is only prospective case series, and it is effective in developed country and found to be effective, but its efficacy decreases with time. Deep brain stimulation, also it is inconclusive. Pulsed radio frequency for dorsal root ganglion and intercostal nerve for thoracic post-herpetic neuralgia is functioning, but also it has a limited duration, about 1 year. This is a study, randomized clinical trial for pulsed radio frequency. Notice he used tramadol in addition to pulsed radio frequency from the start when it was about 6 or 7 for severe pain. Therefore, the pain did not come below 3. In 2018, we published the ultrasound pulsed radio frequency in management of thoracic post-herpetic neuralgia. But the trick here is first we give 2 weeks of pregabalin. 300 milligram per day. This will decrease the central sensitization and bring the pain from severe to moderate, from 7 to 5. And then we did the radio frequency, pulsed radio frequency for intercostal nerve. And this associated with reduction in the pain for about 6 months below 3 on VAS, below 30. This is a great achievement rather than the other paper from China. They started early and found the result is not good. And ultrasound guided the conclusion, BRF for intercostal nerve in combination with pharmacotherapy in management of thoracic post-herpetic neuralgia is promising treatment modality. It provides effective post-herpetic pain control, less analgesic consumption, and significantly improves the quality of life of our patient. Recent review in 2019, this is intervention treatment for post-herpetic neuralgia, the evidence in the pain physician, and the result found that we can use beryllium toxins, triamcinolone subcutaneous, transcutaneous electrical nerve stimulation, peripheral nerve stimulation, paravertebral block, stellate ganglion block are recommended first, followed by pulsed RF. I agree, because of the cost, the price. If pain persists, we can use spinal cord stimulation. And they avoid the use of intrathecal methylprednisolone because it is dangerous and the level is 2. We need more randomized clinical trial. In 2020, in the pain physician, a study from China found that spinal cord stimulation and pulsed RF for dorsal root ganglia both are effective. Remember that it has a duration of effect, not continuous effect. The effect of spinal cord stimulation, it is a spinal cord stimulation is costly procedure, and many complications like infection, migration of the plate, and like this, and decrease its efficacy can occur. And pulsed RF has a limited duration, about 6 to 1 year. At the end of my lecture, please remember that prevention is better than treatment of post-herpetic neuralgia. The 10-step model is effective tool for prevention of post-herpetic neuralgia. The earlier the treatment, the less likely to develop post-herpetic neuralgia. In high-risk group, early aggressive treatment is mandatory. Treatment of post-herpetic neuralgia, sorry, it is palliative. Thank you.
We have some questions for you,
yes,
Dr.
welcome,
Makharita. So let me find the questions here.
Yes.
Here is one. It says, Professor, do you have any experience with ultrasound-guided ESPB for thoracic post-herpetic neuralgia?
Rector spine is facial plane and associated with paravertebral block. The target of our block in post-herpetic neuralgia is to examine the response of the nerve for the local anesthetic. If there is a result, this means that it is still a viable nerve, because post-herpetic neuralgia has some incidence of deafferentation pain. If the pain is not improved with the block local anesthetic, this means that high incidence of deafferentation pain, and there is no result of pulsed radio frequency in patient with deafferentation. It needs spinal cord stimulation. So the facial bland block can attenuate the pain, or per se can attenuate the pain of post-herpetic neuralgia, and can be combined with high doses of pregabalin, like pregabalin 300 milligram per day. So it is also a combination therapy.
Thank you. There is another question for you, Professor. What is the role of opioids, and when should you use opioids for post-herpetic neuralgia?
Yes. the international policy found that opioid is the second step as anti-neuropathic drugs. So we need to use a drug with the ability to bring a result with neuropathic drug. Which drug? If it is pure mu agonist, we need high doses. But for tramadol and oxycodone, tramadol works by different mechanisms, like activation of the descending inhibitory pathway, modulation of the NMDA receptor, this sodium channel block. These mechanisms are effective in post-herpetic neuralgia, while the oxycodone works by its kappa effect. So if it is pure mu agonist, we need high dose of opioid, and this is carry a high risk of abuse. We should use opioid for a limited duration to avoid the abuse of opioid, especially in non-cancer patients.
Wonderful. Do we have time for one more question, Dr. Mahdi?
Yes, yeah, you can.
Okay. Okay, so here's one more question for you, Professor.
Okay.
It says, how long should we use gabapentin for post-herpetic neuralgia?
Yes. Provided that your patient has normal kidney function. My advice to start 150 twice per day, high doses to attenuate central sensitization and to build a trust between you and your patient. This 150 twice per day associated with 30% reduction of his pain. This is documented in the paper. So 300 per day associated with 30% of his pain. And this, after 2 weeks, you can do pulsed radiofrequency, as I did in my publication. So don't start by wild horse. Don't try to catch him. Give some sweetie sedation, then catch him. This is the same idea.
Wonderful, wonderful. Looks like there's one more that's popped up here, Professor. What is the mechanism that stellate ganglion blocks prevent the post-herpetic neuralgia?
Again, remember the evidence. The effect of sympathetic blockade is not conclusive for treatment of post-herpetic neuralgia. Sympathetic blockade for acute herpes zoster to break the cycle of vasospasm of the interneural blood pressure, of the interneural blood vessels, and to increase the oxygen and nutrition to the nerve to avoid the scarring of the nerve. But in post-herpetic neuralgia, if you put the definition of post-herpetic neuralgia 3 months after the incidence of acute herpes zoster, then there is no role for sympathetic blockade. If you put it as 1 month, please try sympathetic blockade, because in some of my patients, it brings a result. So the gray zone is between 1 month and 3 months. Do you know the definition of post-herpetic neuralgia in some books 1 month, and in another books 3 months. For myself, I consider the post-herpetic neuralgia after 3 months. So after 3 months, no role for sympathetic blockade. After 1 month, there is a role in the gray area to use sympathetic blockade.
Wonderful. Thank you so much. I think that's all the questions that have popped up.
Barbara, remember that this is my experience and my colleague in Egypt, and this is documented in our publications.
Wonderful. Thank you so much. Wonderful lecture, Professor.